Radiology of the paranasal sinuses. To study the maxillary sinus, the best view is the Waters view, also called the occipitomental view. The patient should be seated facing the plane of the film upright. The mid-sagittal plane should be perpendicular to the plane of the film. The head should be so extended such that the orbitomeatal baseline or the radiographic baseline is at 45 degrees from the horizontal. Now this is done to clear the maxillary sinus from the superior border of the petrous pyramid. If the extension is not adequate, the superior border of the petrous pyramid will cut through the maxillary antrum and give a false suggestion of a fluid level. If this is suspected, then the X-ray should be repeated with adequate extension so that the superior border of the petrous pyramid is away from the maxillary antrum and is at the inferior edge of the antral lining. This is a plain X-ray of the paranasal sinuses, Waters view, primarily showing the maxillary antrum. Let us study the various features of the maxillary antrum. Plain X-ray of the Waters view is taken with the mid-sagittal plane perpendicular to the plane of the film and the head extended such that the orbitomeatal line makes an angle of 37 degrees with the horizontal. Superior wall of the maxillary antrum. The superior wall of the maxillary antrum is denoted by two parallel lines equidistant on both sides, the superior line of which is the inferior rim of the orbit and the lower line is the floor of the orbit a few millimeters behind. When there is a blowout fracture of the inferior orbital wall, these two lines on one side are telescoped compared to the other, and this is suggestive of a blowout fracture of the inferior orbital wall. Lateral wall of the maxillary antrum. The lateral wall of the maxillary antrum makes a sigmoid curve meeting the alveolar process at an acute angle. If there is erosion of the lateral wall, then this sigmoid curve becomes a straight line. Medial wall of the maxillary antrum. The medial wall of the maxillary antrum is a long plate 5 centimeters in length and when viewed end-on presents as an indistinct shadow. When there is erosion of the medial wall on one side, this side appears less distinct than the other. This is suggestive of an erosion of the medial wall in a maxillary antrum tumor. The head in the occipitomental or Waters view must be sufficiently extended such that the superior border of the petrous pyramid is out of the confines of the maxillary antrum and must be at its inferior edge. If the head is not adequately extended, then the superior border may cut through the maxillary antrum, giving a false sense of a fluid within the maxillary antrum. If this is suspected, then the X-ray film must once again be taken with the adequate extension so that the petrous pyramid does not overlap the maxillary sinus. This is a Waters view of the paranasal sinuses. In this we note that the maxillary antrum on both sides are well developed and the infraorbital canal is separated from the orbital rim. The sphenoid compartments can be seen through the open-mouthed view. This is a plain X-ray of the paranasal sinuses Waters view, showing mucoperiosteal thickening in both maxillary antrum. However, we also note that on the right side there is an air fluid level, and this therefore is a case of acute sinus disease. An air fluid level is a classic manifestation in acute sinusitis. This is a Waters view of the paranasal sinus, showing smooth bilateral outlined retention cyst in a normally aerated maxillary sinus. The drainage of a solitary mucus gland can become obstructed, leading to the formation of a mucus retention cyst. These cysts are often discovered by accident, since they usually do not cause any symptoms. On a plain X-ray, they can be seen as a smoothly outlined soft tissue density without any surrounding mucosal thickening. Plain X-ray skull Waters view. Herein we see a classical tripod fracture. In this, the fracture system is seen extending through the inferior orbital rim and the floor, continuing down through the maxilla. The frontozygomatic suture is also separated and forming as a consequence thereby a tripod fracture of the zygoma. Acute sinusitis usually results from secondary bacterial invasion after viral rhinitis. Chronic inflammation is the one persisting for a period of 12 weeks or more. The Rhinosinusitis Task Force requires 2 or more major factors or 1 major factor and 2 minor factors persisting for longer than 12 weeks to constitute a diagnosis of chronic sinus disease. Major factors for diagnosis include facial pain, nasal obstruction, nasal or postnasal discharge, hyposmia or anosmia, purulence in the nasal cavity, and fever, and this is for acute rhinosinusitis only. Minor factors are headache, fever for chronic rhinosinusitis, halitosis, fatigue, dental pain, cough, ear pain, pressure or fullness. However, facial pain requires another major factor associated with it for diagnosis. The findings suggestive of sinusitis on plain radiography are fluid fill levels, opacification, haziness, and mucosal thickening. Cellulitis with swelling of the cheek produces clouding of the antral air space on Waters view, and this can mimic true clouding due to sinus disease. The differentiation of infection, tumor, polyp, and allergic mucosal thickening may be difficult, and all of these conditions can lead to a false positive diagnosis. Sinus mucosal thickening or opacification may also occur in hematological disorders, fibrous dysplasias, Wegener's granulomatosis, and Paget's disease. Such findings should alert the observer, and a more accurate means of diagnosis such as CT, MRI, endoscopy, and sinuscopy may be employed if doubt persists. The sinus radiographs have to be examined for the presence of evidence of maxillary sinus disease and the standard criteria of air fluid level, haziness, sinus opacification, and mucosal thickening, which is greater than 5 mm as measured at midpoint of the lateral wall of the maxillary antrum. This is used to diagnose sinusitis. Air fluid levels and sinus opacifications are useful features on radiographs, and it is generally accepted that they will make a positive prediction in 80 to 100% of the cases. Haziness and mucosal thickening, however, are less reliable indicators of sinus disease. This shows the skull in a Waters view in 3D.